We are going to commence the lecture on preoperative care. Preoperative care of a surgical patient. Now, the lecture, we are going to have two sessions. The first session is on the lecture, then we'll now talk about, we'll have a session for MCQ, which is going to be an interactive session. So we are going to follow this outline. Now, by way of introduction, when you talk about perioperative care, it is defined as measure to achieve minimal risk from surgical outpatient department to discharge. So from the point of reviewing a patient, from your first contact to the point where you discharge the patient after treatment, okay? All the measures you take to minimize risk of developing complication. Now, you want to pinpoint potential preoperative comorbidities, problems associated with anesthesia, surgery, define and reduce the extent of known risk, discover unknown risk, as well as social aspects of the admission. Now, the overall goal of preoperative evaluation is to reduce the perioperative morbidity and mortality and alleviate patient anxiety. Now, this is achieved through careful history, examination, and investigation. All correctable derangements are observed before surgical intervention. Now, your statement of surgical importance, you should know that stress of surgery may trigger morbidity or mortality, especially in those with underlying medical comorbidities. Now, when there are complications in a patient or patient who is a high-risk patient, now the risk of operating such patients is high. The risk of developing complication in such patients is high. So you should know that surgery itself, especially in major surgery, is stress. And when you subject a patient to stress, they could develop morbidity and mortality. What are the aims of preoperative evaluation? The aims are to assess risk of surgery versus risk of medical or no treatment. There are some certain patients where after treatment, their condition might even worsen. There are some certain conditions where you have to do what is termed masterly inactivity. Okay? You rather not operate, because when you weigh the risk of operating the patient and not operating, you will discover that when you operate, they are more complicated. Okay? Now, You want to identify patients that are of high risk group. Okay, high risk patients. Who are the high risk patients? High risk patients include extreme of ages, patients in the neonatal period, and as well as the elderly patients. They are high risk patients. Patients with medical comorbidities, they are high risk patients. Patients who are obese are high risk patients. Patients with cardiac diseases. So in your preoperative evaluation, you want to identify who are these high risk patients, and you want to take measures to prevent complication. The aim include documents extent of known disease. You have to discover unknown disease via proper evaluation. You plan prophylactic or definitive treatment of comorbid conditions that might complicate or adversely affect surgery. Now you do a careful patient selection. It's not all patients you just operate. You have to do a careful patient selection. Now you must establish rapport, okay, so that you will build trust between you and the patient. Now you have to understand some certain terms when it comes to the perioperative management of a patient. The pre-op period is the period before operation, okay? It is the period where patient present to you in the clinic or at the emergency, where you optimize all the arrangements and, okay, you now proceed for operation. So that is the pre-operative period. The intraoperative period is the period wherein patient is taken into the theater, including the anesthetic intervention from intubation up to the point of recovery of the patient. That is the intraoperative period. During the intraoperative period, there is a period where you have anesthetic intervention as well as the commencement of the procedure. The post-operative period is the period from recovery up to the discharge of the patient. Then you have the perioperative period, which is the period of pre, intra, and post-operative period. This comprises the perioperative period. The per-operative period, it is the period during the operation. That is the intraoperative period where the surgeon commences his operation. Okay, the intraoperative period, you know, there's the anesthetic time and there's the operation time. Now, the per-operative period is the period during the operation. Now, there are various types of surgery you need to know, and surgeries could be classified as immediate or emergency surgery. Here, life, limb, or organ is threatened. Now, immediate surgery occurs within minutes of making a decision to operate, and patient is resuscitated simultaneously. So there is no any delay in surgery because of resuscitation. Both the surgery and the resuscitation occur concurrently. Sometimes even the surgery is part of the resuscitation. It's a life-saving procedure. You can break into an existing list, okay, if required. Example, when you have a ruptured aortic aneurysm, maybe you have laparotomy for hemorrhage. So in this condition, you do not delay any form of treatment, okay? So this is called an emergency or an immediate surgery. Now you could have an urgent surgery. An urgent surgery, most of the surgeries we call emergency surgeries, they are not actually, what do you call it? Emergency, okay? Here, in this condition, patient is actually resuscitated, okay? Before you take the patient for surgery, you have to resuscitate the patient, okay? Now, interventions for acute onset clinical deterioration of life, limb, or organ, okay? Now, it normally occurs within hours of decision to operate, and once resuscitation is completed, patient is proceeded to have. When you have laparotomy for peritonitis, debridement for gangrene, fixation of multiple fractures, okay, all these will be regarded as an urgent operation. Operation could also be classified as expedited, where patient is stable but requires early intervention, okay, but not an immediate threat to life. It normally occurs in days within the decision to operate. Now, the condition the patient have is a potential threat when they are left. So there's tendency of that condition to become an urgent condition. So example, excision of tumor with potential to bleed or cause obstruction. To say an elective surgery, it is a planned or booked in advance of routine admission to the hospital. The planned operation or elective operation, they are planned in time that suits patients, the hospital, and the staff. Usually there's a booking list for an elective procedure. And for elective procedure, you ensure all the arrangements are corrected. There are various ways also you can classify surgeries, okay, like major, intermediate, minor surgeries, day case, or inpatient. In day case, patients will have their surgery and they are discharged post-operatively. Now, the pre-operative care. Now, you should know that any patient that is presenting as an emergency, okay, resuscitation takes priority over all other measures you want to take. Resuscitation takes priority over your investigations. So for an elective or booked, you have to fully evaluate, because a surgical patient who presents as an emergency or an urgent presentation who is not properly resuscitated will end up having complications. For example, When a patient presents with generalized peritonitis and you rush to operate a patient who is dehydrated and have this electrolytemia, so there is high tendency of patient developing complications. So you will have high mortality rate. Now, for elective cases, you have to make a diagnosis. Your important priority in an elective case, your first priority is to establish the diagnosis of that condition. Because without a diagnosis, you will mismanage a patient while his underlying disease condition progresses. So the first thing you do is to establish diagnosis, and this you start by taking a history. Okay, you take a detailed history to find out the diagnosis, risk factor in that condition, past medical history, surgical experiences, comorbidities in the patient, drugs, family and social history. You do a physical examination. You do a general physical examination to assess the general well-being of the patient. And also, if required, you do an anthropometric measurement. Okay, then you do a thorough systemic examination. This will include the affected system, okay, to look at your diagnosis and the extent, then the other systems for concomitant pathology. Because if you remember the aim of perioperative care, we said to determine the extent of the disease and to discover other concomitant diseases. So you have to do a thorough systemic examination. Now, your investigations when evaluating a surgical patient, you classify your investigations into diagnostic investigations, staging investigations, and baseline investigations to prepare patients for treatment. Diagnostic investigation, usually histological diagnosis is required for some certain or most surgical condition where you take a biopsy for histology for confirmation of your diagnosis. The staging investigation is to determine the extent of disease or spread. Various types of imaging can be used to assess involvement of an adjacent organ or involvement of distant metastasis. Your baseline investigations are those investigations to prepare a patient for treatment. And these investigations will include your routine full blood count, urea electrolyte, creatinine, genotype, fasting blood sugar, urinalysis, stool microscopy, all the baseline investigations, and also grouping and cross-matching. Now, you have to optimize your patient. Patient needs to be adequately optimized. Now, there are some certain conditions that require specific treatment in the preoperative period. Patients with obstructive jaundice, because they have risk of developing hepatorenal syndrome, you need to hyperhydrate them until they are producing up to about 60 mL of urine per hour in an adult. Okay, you want to give them up to 1.5 their daily maintenance to prevent risk of developing hepatorenal syndrome. You give them vitamin K because of the deficiency of vitamin K dependent clotting factor, which is a component of the vitamin K which is component of fat-soluble vitamins. Okay, so when vitamin K is absent, they do not produce the clotting factors 2, 7, 9, and 10. You give intravenous antibiotic to prevent the risk of developing ascending cholangitis, and also you want to optimize their INR. Okay, if after giving vitamin K for 5 days you repeat the INR, if it's less than 1.3, it has to be greater than or equal to 1.3. If it's more than, if you want to achieve 1.3, if it's far greater than 1.3, patients have tendency to bleed. So you give, if after giving vitamin K for 5 days and patients is still having clotting arrangements, increased INR ratio, so you will give fresh frozen plasma. Okay, now for colonic surgeries, especially the left-sided colon, you want to do a bowel preparation. Okay, for left-sided colon, you want to do a bowel preparation because of fecal load. You want to get rid of bacterial and fecal load, because if a patient have the colon loaded with feces and you are doing surgeries, there's high tendency of anastomotic leakage. Okay, now in intestinal obstruction, you want to pass NG tube to decompress to prevent patient from aspirating. Now you optimize fluid and electrolyte derangement. For pelvic surgeries, you want to pass catheter to empty the bladder to prevent risk of bladder injury. Diabetic patient, you have to achieve glucose control, and after achieving reducing the presenting glucose, you now place a patient on GKI, glucose potassium insulin infusion, while patient is on MPO while you try to operate. Then in hypertensive patient, of course, you have to optimize their blood pressure to prevent intra-op bleeding, arrhythmias, cerebrovascular accident. If a patient is not optimized, a hypertensive patient not optimized, they even have a risk of developing stroke intraoperatively. So you have to control their blood pressure preoperatively. Patients are maintained on nil per oral to achieve an empty stomach, okay, while they are on maintenance IV fluid to prevent hypoglycemia. So in the preoperative period, when you place a patient on NPO, don't forget to place that patient on IV fluid, okay, glucose containing fluid. Give him the normal maintenance fluid to prevent patient from going into hypoglycemia. And you have to obtain an informed consent where patients understand their disease condition, the treatment you want to offer, the various treatment options and their complications. You have to explain in detail to the patient, then he now sign consent for your treatment. There are several anesthetic considerations in the preoperative patient. Now, the anesthetic considerations, there is a risk assessment by the anesthetist, okay? When they do the risk assessment, they now categorize their patient, okay? Then there's also careful intraoperative management and monitoring, okay? Now, we'll talk about the risk, the common risk. There are various risk assessment tools the anesthetists use in the preoperative period, but however, we'll just talk about two of them. Now, in the intraoperative period, the anesthetists on their monitor, they should carefully monitor the vital signs of patient, monitor the ECG, the SpO2, pulse rate, blood pressure, mean arterial pressure, then plus or minus capnography, the urine output. Okay. Now, intra-op aim is to achieve smooth induction, okay, and recovery, as well as smooth intraoperative course. Now, because sometimes most of the challenges the anesthetist may have is at the induction of anesthesia. They may have difficulty at intubation. Patient might aspirate during intubation if the stomach is full. Okay. Now, patients might also aspirate during recovery if the stomach have not been emptied. Okay, so you want a smooth takeoff and a smooth landing, as well as a smooth intraoperative course of anesthetic delivery. Now, the American Society of Anesthesiologists, they group patient, they classify patients into 6 classes, class 1 to 6, and E is added to each of these classes if it is an emergency surgery a patient is undergoing. Class 1 are healthy patients. There is no background comorbidity. A healthy patient coming for surgery, okay? Maybe they don't have any systemic illness, no any comorbidity. They are coming for surgery. So you regard them as class 1 patients. Now, class 2 patients are mild to moderate systemic disease. Mild to moderate systemic disease, a hypertensive patient whose hypertension is controlled. That is ASA 2. Okay. Now, ASA 3 is patient with severe systemic disease. For example, an uncontrolled hypertensive patient who is undergoing a major surgery. That is ASA 3. Now, when you have an incapacitating or life-threatening systemic disease, since we are using hypertension as an example, a patient who already developed a complication of hypertension, say stroke, and he's coming for surgery, okay, that is an ASA 4 patient. Then class 5 is a moribund with little chance of survival with or without surgery. Now, in such cases, you have to be signing a high-risk consent if you have to operate on such patient, okay? Even patient with class 4, you have to sign a high-risk consent. Now, usually ASA 6 are brain-dead patients, okay? And most of them are patients for organ donation. Another parameter the anesthetists use is the Malampati score, a score system that relates the amount of mouth opening, okay, to the size of the tongue and provides an estimate of space available for oral intubation, okay, by direct laryngoscopy. So you have class 1 to 4, okay? So you can see from the images, Malampati 1, class 1, there is complete visualization of the soft palate. You can see intubation will be easy here, okay? Class 2, complete visualization of the uvula, okay? Class 3, you have visualization of only the base of the uvula. and class 4 you have soft palate is not visible at all. So you can see the increasing class, you have increasing difficulty in intubation. Now, what are the measures the anesthetic take intraoperatively? Okay. Now, all anesthetists usually check their instrument before even intubating. I had an experience of anesthetist. We are about to do a surgery. He forgot checking his equipment and he paralyzed the patient. Of course, he tried to open his machine and it got stopped. He could not, after giving muscle relaxant, and of course he could not open his inhalational agent. The machine got stuck. So as a rule, you have to check all your equipment before commencing the procedure, or else you run into trouble. Now, it is after patient is anesthetized, then you now position the patient properly. Okay, and care should be taken in some awkward position like prone position, not to displace the tube unknowingly during positioning of the patient. Now, careful intraoperative monitoring, which we mentioned all the parameters. We said the SpO2, the pulse rates, the mean arterial pressure, the blood pressure, okay, the ECG, temperature, urine output, plus or minus capnography, the carbon dioxide concentration. Now, these are some intraoperative problems you need to note, some intraoperative problems which may develop, okay, and patient might develop hypotension intraoperatively, and this is due to hypovolemia from blood loss. And if this hypovolemia cannot be controlled and it progresses, it will lead to shock and subsequently cardiac arrest. Okay, patient might arrest on table. So all these intraoperative anesthetic considerations should be considered. Okay, and the anesthetist should be on alert on any cause of hypovolemia. Patient might have hypertension, and this could be caused by a hypertensive patient ab initio. When you see hypertension, it might be a hypertensive patient. It might be due to pain. Intraoperatively, pain can cause hypertension. Okay, hypertension can also be caused during endotracheal intubation. You will see the BP rising. Some of the anesthetic drugs like ketamine will cause hypertension. Patient might develop anemia from blood loss. Patient might have malignant hyperthermia, okay, like some of the anesthetic agents. They could have arrhythmias from vagal or sympathetic activity. They may have cardiac arrest from hypoxia, hypovolemia, cardiac failure, embolisms. Now, they may have hypoxia from respiratory obstruction. They may have vomiting and aspiration. So these are important measures that these are important problems that the anesthetist should be aware of. Now, there are some special patients, as we mentioned earlier on, or high-risk group for surgical operation because of the risk of developing complications during surgery. Okay. Now, sickle cell anemic patients have risk of developing crisis, vaso-occlusive crisis due to the stress of surgery and anesthesia. So measures should be taken, and some of the triggers of the crisis will include hypoxia, okay, dehydration, sepsis, hyperpyrexia, and so on. Now, obese patients are also regarded as high-risk patients because of their short neck. They have difficulty in intubation, okay? They have risk of developing DVT, myocardial infarction, cardiovascular accident, okay, and some mechanical problems, lifting of the patient, bed sores, and reduced mobility of patient. Now, all this will make them prone to complications. Now, jaundice patients have risk of bleeding, hepatorenal syndrome, and infection, okay, ascending cholangitis. Now, diabetic patients may have risk of poor glycemic control, hyperglycemia, and this can progress into diabetic ketoacidosis, okay. Now, they may have this electrolytemia and some renal complications that are related to diabetes mellitus. Now, elderly patients have risk of comorbidities as well as hypertension. Then the neonates will have risk of hypothermia. Now, cardiac patients, okay. Now you have to treat cardiac patient for at least 1 week, patient with myocardial infarction for at least 1 month. Then you have mortality of aortic stenosis is as high as 50%. As we mentioned, neonates will have hypothermia, hypoglycemia because of their poorly developed liver, as well as fluid overload. Patients with liver disease have risk of coagulopathy, where you have to give fresh frozen plasma or vitamin K, and they have risk of developing encephalopathy. So all these special patients are regarded as high-risk patients. Now, post-operative care. Now, after the operation, okay, we said the post-operative period from the recovery up to the discharge. Now, after the operation, patient is not taken directly into the ward. Patients have to be moved to the recovery area where they have to stabilize all the vital signs, because if patient is not stable, they cannot be moved to the ward. Rather, they are moved into the intensive care unit or HDU, as the case may be. So the aim of the recovery period is to ensure stable and optimal vital signs, because of course, if the nurses come to pick the patient and they see any unstable vital sign, they will not pick the patient to the ward. In fact, you as the surgeon, along with the anesthetist, when you see high risk of instability, you rather take patients to the ICU, because if you take them to the ward, they have tendency of developing a complication, or even they might be mortality. Okay. After recovery, patients are taken to the ward, and all the treatments that are prescribed should be started immediately. Now, during the immediate post-operative period, you should ensure a patient have patent airway, okay, and patient is receiving adequate oxygen with an optimal SpO2. Now, there should be early commencement of analgesia and other post-operative order. because you don't want patient after recovery from anesthesia, he's complaining of pain. Okay, you don't want that. You prevent post-operative nausea and vomiting. This patient might just aspirate during the recovery period. And nil peroral is maintained until patient bowel sounds are achieved. Now, IV fluid to ensure adequate perfusion, rectal catheter for bladder care. Now, if you do an operation, for example, you do a resection and anastomosis, and patient is not adequately perfused, is not receiving adequate fluid therapy, that anastomosis have a risk of breaking down because there will be reduced perfusion, ischemia, and necrosis. If patients have anemia post-operatively, they stand chance of anastomotic breakdown because of ischemia and perfusion. There will be no adequate oxygen delivery to the site of your anastomosis to heal. Now, you should commence early ambulation to prevent deep vascular thrombosis, deep venous thrombosis. Now, you should commence early wound care. You should know that most of the clean surgeries, within 48 hours, you have epithelialization of the scar, except it's a dirty or a contaminated wound where you have continuous or purulent discharge. But usually clean incision, within 48 hours, patient can even take their bath because you have expected epithelialization to have occurred. Okay, now you have to care for the wound to prevent surgical site infection. Now, post-operative packed cell volume and urea electrolyte creatinine is usually done after 48 hours of surgery, where you have expected adequate redistribution of the various compartments, and patient's true picture of true blood picture will appear. Okay, so it shouldn't be too early or too late, because in the post-operative period where patient is subjected to stress and anemia, okay, they have risk of developing wound complication because of anemia. They have risk of developing anemic heart failure. So the post-operative PCV is very important for you to monitor, and the U&E, if there's electrolyte derangement, you correct. Now you care for the drain, make sure it is not kinked, is draining adequately, and if there's any blockage, you have to take care of the tube as well as the container, as well as the site where the drain is placed, where you have to be dressing regularly, and you monitor the effluent. As long as the drain stops functioning, you have to remove the drain to prevent an abuse of drain. Don't forget specimen for histology, because it is when you have a specimen you can do a definitive treatment. Okay. Now, the post-operative care, for the post-operative care, you want to do an adequate stomach care, okay? You want to prevent surgical site infection. You want to commence early physiotherapy. You want to rehabilitate patient, and you want to start your adjuvant therapy, okay? Now, what are the complications of perioperative management? Now, the complications are untoward effects that occur within 30 days of an operation, okay, or up to a year, or greater than 30 days but they are directly related to that surgical procedure, and they are classified as immediate post-operative complication, early post-operative, and late post-operative complication. Now, the immediate post-operative are usually anesthetic complications. Most of the complications you see within 24 hours, most of them are anesthetic complications. And most of the mortalities you see from within 24 hours, not from hemorrhage, of course. You like respiratory insufficiency, cardiovascular emergencies, recategorization, especially in patients with hypokalemia, reactionary hemorrhage, okay, when patients recover from anesthesia, especially in hypertensive patients, hypothermia in neonates, okay, hypoxia in sickle cell, hyperpyrexia. All these are immediate complications. Then early post-operative complications usually occur after 24 hours, and they include atelectasis, tracheobronchitis, pulmonary embolism, myocardial infarction, DVT, post-operative nausea and vomiting, ileus, peritonitis, jaundice, okay, urine retention, acute renal failure, UTI, delirium, hematoma, surgical site infection, and dehiscence. Now, late complication, okay, they occur after 30 days, but they are directly related to the operation, like prolapse, okay, incisional hernia, adhesive intestinal obstruction, intracutaneous fistula, sinuses, recurrence, keloids. Now, in conclusion, we should know that proper perioperative management is the key to a smooth, successful conduct of surgery and anesthesia with a reduced morbidity and mortality. So we've come to the end of the lecture now. I'll now entertain questions. Okay, you can ask your questions, please. Yeah. So.